So I'm going to talk about oncological emergencies in older patients. And so I'm going to start with a case from UHD. This is a 68-year-old woman with a history of a blood problem, according to her home health aide. She presents with 1 week of abdominal discomfort, anorexia, generalized weakness, and 2 days of lethargy and confusion. Her meds are hydrochlorothiazide and metoprolol for hypertension, and she's had recent pneumonias. Right? Her vital signs, initially, she's afebrile. Her pressure is a little bit on the high side. She's not tachycardic. She's breathing about 14 a minute, but she looks sick and she looks very dry, lethargic. She's only oriented ×1, and that's only been for the last couple of days. She has no focality, but her conjunctiva are very pale. Her chest is initially clear on exam. Heart and abdomen are benign. We got an EKG, and it showed the following. So anybody want to interpret that EKG for me, the abnormality? We can keep the lights off. Anything hit you on that EKG given this presentation of altered mental status? Right? Because EKG always has to be interpreted. It's a test, and it has to be interpreted in the light of your patient, right? Your history and your physical. Anything anybody want to say? Anybody want to make me proud of having me say I taught you this, even if I didn't? Anybody? Wow. Okay. What did you see here? Just what do you think is abnormal here? Good. Oh, intervals. So rate rhythm, you're right. Always should start with rate rhythm, maybe axis. But what about intervals here? Anything kick you in the pants? Yeah, it doesn't look too prolonged. Does it look any other way? Given that this patient has some kind of blood disorder and is now have altered mental status and is dry? So this is a short QT, and there are very few things that can cause a shortened QT interval, right? So what's one of them that might also called altered mental status, and you might see in someone with a malignancy? Say it loud and proud. I'm a poet and I don't know it. Okay. So anyway, let's get to our differential. But right, so we have a woman changing mental status, some kind of blood disorder, who is very dehydrated, weak, and has this abnormal EKG maybe, right? Not a very impressive EKG unless you fit it in. So when I think about differential diagnosis, I always like to spit out the diagnosis, right? So the first thing we always think about is the serious things you don't want to miss that can kill the patient soon, right? And then probable, what's most likely given the history and physical. And then interesting, out of the box diagnoses, although all patients should be interesting to you, right? For two reasons. One, you can learn from every patient, and two, they're people, they're patients, right? And we always take good care of our patients. And treatable. You want to not miss things you can treat. Yeah, this person's in coma. I don't want to miss hypoglycemia. Oh, this person's in coma. I don't want to miss a narcotic overdose, right? Because they're so easy to treat. Oh, this patient is septic. Well, I don't want to not give them antibiotics, right? Because I can treat that. So you always want to kind of spit out that diagnosis. So the major presentation here is for altered mental status. Oh, okay. So technology. I'm not very good at it. Just ask Danny. He'll tell you. Gernsheimer's always screwing up his charts. But anyway, so an acute change in mental status is delirium, right? And older people, when they have delirium, they don't have this wild thing like someone on angel dust, right? Where they're knocking down 3 people and, breaking up the quiet room and that kind of stuff and hitting Gernsheimer with the bed. No, it's the majority of older people who have delirium are confused, but it's called a quiet delirium, like this patient has, right? And there's a differential for it, right? So the differential is based on the mnemonic delirium. So drugs, dehydration, diabetes, either hypo or hyperglycemia, electrolytes, particularly sodium, calcium, and endocrine stuff, hypo and hypothyroidism, lack of drugs, withdrawal, infections, especially, probably the most common in my experience are infections and dehydration, respiratory stuff, hypoxia and hypercarbia, intracranial things, strokes and masses, uremia, which we see all the time at UHD. Every shift, we must see 4 or 5 people who are on dialysis, at least that, right? And then M is myocardial stuff, acute MI, bad CHF with hypoxia, and metabolic things. Okay. Did I screw that up again? No. No, that's good. No, I didn't. So we get a call from my favorite thing when I'm working in the ED. I'm here taking care of patients. I'm here getting yelled at. The social worker and care management come and say, Dr. Gernsheimer, why are you admitting that patient, or put it down as an OBS? And I'm in the middle of all of that, and I get a call from the lab. And there's a critical value. The calcium is 16. Right? Oh my God. OMG. So normal calcium is 8.7 to 10.4. Ionized normal is 4 to 5.6. Mild hypercalcemia is 10.5 to 12, and they're usually asymptomatic. Moderate is 12 to 14. And a severe hypercalcemia is greater than 14 or greater than 12, but with severe symptoms, especially altered mental status. Right? And you can correct the calcium, as Dr. Gutierrez pointed out, although I'm not very smart and I'm not very good with numbers, but you always, if they're hypoalbuminic, you can correct it by using this formula. And for every change in albumin down 1, the calcium falsely goes down by 0.8. All right, so let's talk a little bit about hypercalcemia, right? So it's increased frequency in the elderly. Mortality from it is greater in the elderly. Malignant hypercalcemia is greater in the elderly. And although we're not going to talk about it here too much, hyperparathyroidism, which is the second most common cause of hypercalcemia in the elderly, is also more common in the elderly. So it's like that movie Perfect Storm, when they go out to fish and they get caught in the storm. When older people get sick, and especially they get hypercalcemia, they're in worse trouble than younger people, which is true about most things. Okay, so why do older people get severe hypercalcemia? So they have an increased incidence of malignancy especially, but also of hyperparathyroidism, but especially we're going to talk about malignancy. They're on increased drugs that increase calcium, particularly diuretics, especially thiazide diuretics is the one that you always got to worry about. A lot of people are on hydrochlorothiazide, and there's some others. They have a decreased renal clearance of calcium, and often their creatinine clearance is lower than younger people. They have an increased GI absorption and bone resorption that leads to hypercalcemia. And they have more comorbidities that cause them to be more immobile and dehydrated, right? And we see it all the time. People coming in with decubit eye, because they can't get out of bed, and their bones break down and their skin breaks down, and it's an imperfect storm in a certain way. Terrible, right? So what are the causes of hypercalcemia in the elderly? What's your differential here? So number one is malignancy. Two would be hyperparathyroidism. Others less common, hyperthyroidism, drugs, including vitamins and hydrochlorothiazide, granulomatous diseases, less common, Paget's disease, and immobility, which adds to everything else, right? You have cancer, you're immobile because you're weak, and now you, on top of that, now you're not moving around, you get hypercalcemia more. So what are the most common malignancies that cause hypercalcemia, right? So multiple myeloma, which I'll per patient after a chart review. And I got to admit, I'm not that very good at Health Bridge. So when I saw this patient, it took me about 15 minutes to figure out how to do the chart review. But I asked Esther Kwok on this patient, and she showed me. Second most common cancer that can cause this, others, prostate cancer, breast cancer, lung cancer, less common, thyroid cancer, and renal carcinoma. Lymphomas also can do this, and I've seen it once only from a lymphoma, because they cause something, they cause calcivitrol, which is a vitamin D, kind of an activated vitamin D imitator. So they're actually kind of causing hypervitamin D from lymphomas. But these are the most common ones you're going to see that are going to give you hypercalcemia, right? So what's your workup? So in all cases, you always start with the history, right? Everything always starts with the history, a good history. And then you're going to do your physical. You're going to get a CMP. You're going to do a rapid because you can, if you're worried, because you're going to get your electrolytes, your potassium and your calcium back quickly. You're going to get your phosphate. You're going to get a urine analysis. Make sure they're not in renal failure. Make sure they're not septic. If you're worried about hyperparathyroidism, you can get a PTH level. And for malignancy, you're going to do a malignancy workup. If you're worried about myeloma, you're going to do electrophoresis. You're going to do imaging to look at the bones involved. And you might send a parathyroid hormone level that cancers can cause, that PTHRP. That's kind of a fake hyperparathyroid hormone that a lot of malignancies will make. And that's one of the ways they'll break down bone, either the direct invasion, but also by making this hormone. So you can actually test for that. If you're worried about hyperthyroidism, you can get free T4 and a TSH. For vitamin D overdose, you can get vitamin D levels. And then for granulomatous disease, you can get a chest x-ray, you can do an ACE test, and you can get bone x-rays if you're worried about multiple myeloma and Paget's disease. Okay, so how are you going to treat this? So for mild, you just can confirm that they really have hypercalcemia. If you keep on a tourniquet sometimes too long, you can get false hypercalcemia, right? So you want to make sure you get a good sample and you confirm it if it is high. You want to stop any exacerbating drugs like hydrochlorothiazides or supplements or weird diets, right? You want to encourage oral hydration and mobility if you can, and you want to arrange for follow-up. Moderate, you treat as mild unless it's symptomatic, and then you treat it as severe. So how do we treat severe hypercalcemia, right? So always ABCs and monitor, right? Always, right? We're emergency physicians. We may not be as smart as a neurologist, but we are good at telling sick from non-sick, and we are the best at doing the ABCs, right? Right. Okay. So you're always going to start with, unless there's signs of CHF, almost always these patients are very dry. Why? Because when they keep in calcium, you lose sodium. You affect the kidneys and you put out sodium, and with sodium goes fluid as you're keeping in this calcium. So you're going to be almost always dry, right? So you're going to start with IV hydration. And some studies have shown that people who are hypercalcemic are usually anywhere from 3 to 6 liters behind, not counting maintenance. Now, if you fluid overload them, so I always at least start with 2 liters of normal saline. And why you want to use normal saline is when you keep in sodium, you get rid of calcium and vice versa. So you want to, if you keep in the sodium, you get rid of calcium. And that's your number one attack in the ER. You're going to hydrate these people well. Obviously, they're elderly. Some of them have underlying CHF, underlying kidney disease. So you got to watch them, right? So you could give a liter and reassess. You give the second liter, reassess, right? You're always going to reassess. Whenever you take an attack, you're going to reassess. So you want to hydrate really well. And most of the time, I've had to give 3 liters at least. If they become fluid overload, in the old days, on purpose, you give a lot of fluid and give Lasix. But nowadays, most experts will say, only give Lasix if you fluid overload them. Otherwise, just give them the fluid. Now, what else can you do? So as Dr. Gutierrez mentioned, you can give them an IV bisphosphonate. And the one that is used is arachidonic acid. But that takes a few days to work, right? And the dose is 4 milligrams. You can give it anywhere from 30 minutes to an hour, right? But that takes a few days to work. And that's only done in very severe cases, at least initially. One thing you can give that works quicker, doesn't work for every cause of hypercalcemia, but usually the endocrine people, especially at UHD, will recommend it for very severe hypercalcemia, is calcitonin, right? And the dose I start with is 4 international units, 4 units. You can, if it's not working, you can go up to 8 Q12H. So it's 4 statin and 4 Q12. Or if it's not working, you go up to 8 Q12. It only lasts for about, even when you give it every 12 hours, it becomes tachyphylaxis. So you got to use more of it, maybe 4, then go to 8 every 12, but then it stops working. And that's why, if you're really worried, you're going to add on arachidonic acid, ZA, because that's going to really work well, but takes a while to work. But always, anyway, you're going to start with your IV hydration, right? That's what we do in the ER. And especially when I have you guys around, I say, and the nurses can't get a vein on this poor dehydrated elderly person who's been stuck millions of times, I go and beg one of you guys and I say, okay, could you get an IV for me? And I have to say, not one of you have ever said no to me, right? Because I'd have to report you to Dr. Willis anyway. And if you did, and he's a tough guy, like a marshal, I mean, he is a tough guy. So anyway, and then you always want to load the boat. You want to get some expert stuff. So you can get renal involved if they have renal problems. You can get endocrine involved. You get hem-onc involved. Don't ever be afraid to load the boat. Remember, your aim is to get patients better, wherever it is. It's something like this, or it's adult epiglottitis, right? You need help. Don't be too proud, right? For me, I like the old song by the Temptations, I ain't too proud to beg, whether it's to ask you guys to put in an IV or to get a consult, right? All right. So some special treatments, always you're going to treat the underlying cause. And if it's a malignancy, you're going to you may not do it yourself, but you're going to make sure heme gets involved. There's a drug called I can't even pronounce it with my dyslexia, but denosumab. and it's for resistant hypercalcemia. Recently, one of the endocrine societies come out and say maybe that should be used even ahead of zerodonic acid or pamidronate, which is another bisphosphonate, not as good as ZA. But most experts still kind of first go with calcitonin and ZA rather than this drug. But for resistant malignant, you sometimes see this drug. Also for parathyroid cancer, there's sinosalate. If it's hyperparathyroidism or parathyroid cancer, then you're going to need surgery at some point. For granulomatous diseases like sarcoid and for hypercalcemia with lymphomas, because they make this fake vitamin D called calcitriol, steroids work very well, 20 to 40 milligrams of prednisone a day. And then obviously for really life-threatening, dialysis or for resistant. And I had a patient at Lincoln a long, long time ago in another lifetime that had a calcium of 20 and was really going down the tubes, and we actually got dialysis. I had to promise my firstborn there, but I did get dialysis done. Okay, so the patient follow-up, she had a history of multiple myeloma. She then spiked the temp to 102. Her chest, when I re-listened to her, she had some rows, and at first I thought I fluid overloaded her, but which I've been known to do. But it turned out she had a pneumonia. She also had a swollen, tender left leg, especially the calf, and a DVT ultrasound was positive. Her chest x-ray showed a left lower infiltrate and lytic lesions of her ribs. Her hemoglobin was 6.8. Her creatinine was 3. Her BUN was 60. Her serum protein was 9.2 with an albumin of 3. And her urine was positive for protein. Okay, so she had multiple myeloma. We gave her 3 liters of normal saline in the ED, and her calcium decreased to 13. She was given calcitonin. She was given IV antibiotics. She wasn't bleeding. I did a rectal, and she had no bleeding, so I gave her IV heparin. We transfused her a unit of red blood cells in the ED because she was anemic and started becoming hypoxic from her pneumonia. And we admitted her to medicine telemetry unit. So myeloma, second most common hematological malignancy, more common in older men and people of Afro-American, Afro-Caribbean descent. Most diagnoses of MM are suspected and made in the ED. So a recent study showed that 60% of multiple myeloma was suspected diagnosis by the ED. It's at least, if we can treat it, we can at least suspect that diagnosis, right? And the same study said, although multiple myeloma is not curable in the long run, it keeps coming back, but with early diagnosis and treatment, 10-year survival, greater than 10-year survival. So it's worthwhile picking it up early. Right, so multiple myeloma is caused by proliferation of monoclonal plasma cells, produces abnormal proteins, right? Crowds out the normal blood cells and invades normal tissues, and it interferes with normal structure and function. It interferes, for example, now you're not making the normal, your normal antibodies, right? And other things. So you're really prone to infection when you have multiple myeloma. Most people present with bone pain, fatigue, and weight loss. Complications like this woman, severe anemia, pathological fractures, and even spinal cord compression. They can have bleeding, coagulopathy, like our patient had a venous thrombosis. They can get something called a hyperviscosity syndrome. Anyone ever seen hyperviscosity syndrome here? What did you see, Schechter? I picked on him. I'll pick on you now, another director. Yeah, So the classical triad is something neurological, altered mental status, headache, even stroke-like syndrome, vision problems, and mucosal bleeding caused by these super amounts of gamma globulins and antibodies. And I've only seen it twice in all these years, but you don't want to miss it, right? And you can treat it. Plasmapheresis is the ultimate treatment, but if you can't do that and they're not super anemic, you can take off a unit of blood if they're not anemic. This woman, you couldn't do that. And she didn't have hyperviscosity syndrome. And you can give them saline. So you can take off a unit of blood and replace it with saline. Infection, very, very common in multiple myeloma, especially pneumonia, which this woman had. Renal injury, which this woman had. And hypercalcemia, which this woman had. And altered mental status, which this woman had. So you want to do your CBC, your CMP, your UA, a serum and urine protein electrophoresis, and get x-rays. And the main thing is you want to suspect the diagnosis and you want to recognize and manage complications. Right? That's the main thing we're going to do. We're going to recognize it, but we're going to treat the complications. Right? And you have to think about it. Right? Because the eye doesn't see what the brain doesn't know. So if you don't think about this diagnosis, you're going to miss it. And you're going to miss complications like this until it's too late. And we say in Yiddish, it's ochen weh for you and the patient. Just too bad for you and the patient if you miss it. Right? So you want to always, even if they're not that sick, you want to make sure they get good hematology, oncology consults and follow-ups. Almost done. Right? Other oncological emergencies that we won't cover, cord compression, supravena cava syndrome, SIADH caused by cancers, tumor lysis syndrome, adrenal insufficiency, pericardial effusion, hypercalcemia we mentioned, hyperviscosity syndrome, myelosuppression leading to anemia, bleeding, infection, and neutropenic fever. These are all things you should think of when you hear a patient has a diagnosis of cancer and complications you should look for. And all of us, I'm sure, have already probably seen cord compression from prostate cancer and things like that, right? So in summary, hypercalcemia is common in the elderly, mainly due to malignancy, but sometimes hyperparathyroidism. Symptoms, the bones, moans, groans, stones, and they look dry. The treatment, IV fluids, maybe xerodonic acid and calcitonin, and you're always treating the underlying cause and treating other complications. Multiple myeloma, suspect the diagnosis, recognize and manage complications, and load the boat. Any questions? So these are my references, and the reason I gave references, I usually don't, because I make them up. But in this case, I gave this reference because the first reference there was an article that we had with one of our past residents. You guys might remember him, Abdullah. And he was my geriatric mini fellow. One of only two I really had.